Ebenezer Maradesa is a data scientist and a software engineer who builds AI products. He is resident in Abuja, Nigeria. So I think that was an oversight. So he's a software engineer, he's a data scientist, and he builds and integrates artificial intelligence solutions here in Nigeria. So
yeah, so we go ahead with the challenges of AI in healthcare. The introductory slide, AI in healthcare offers transformative potential, also brings challenges, a lot of them, and navigating them is essential to harnessing AI's full benefits for enhancing patient outcomes and healthcare delivery. So we cannot, there's no one that will be interested in building AI products for healthcare and will not have to deal with these challenges, because healthcare on its own is a particularly challenging field, is a unique field. It's not like every other field. There's been a lot of explosion around fintech recently, and people thought they could replicate the same thing around health tech, but it has not been such an explosive success as it has been with fintech. So health tech on its own is particularly challenging. When you now bring AI into it, it's a whole different scale. It's a whole different scale of challenges. So we'll just explore a few of these. And I think the most important is data privacy and security. Because see, there's no AI without data. There's no AI rather without data. You want to build an artificial intelligence system, you have to have data. Some systems are built on data sets that contain millions of records. We're talking up to 250 million records, up to billions of records, a lot of data. And this data has to come from somewhere. Where is it coming from? If you want to build this to be used by people, it has to come from people. And we know that sharing data in healthcare is a problem. There's a lot of regulations. There's the patient confidentiality factor to it. You can't just share someone's data anyhow. You can't just sell someone's data anyhow. There are regulatory bodies. You could get arrested. You could get penalized. So you want to build a system. You have this fine idea in your head, and then you realize that, okay, you need data of all diabetic or endocrinology clinics for the past, say, 20 years. And then who is going to release all this data to you? That's a problem. So because health data is particularly kept private, kept secured, and there is always this reluctance to share them. And not just reluctance, but the regulations against sharing them anyhow. So that's a major challenge. So if you can't get your data, you can't build your AI model. Okay, so apart from the privacy and security issues, still on the data, number one, accessing, or let me not say number one, going forward, accessing the data is a problem. So even when the data is shared, it's usually shared within closed communities. So for instance, MIT might have a data set. For instance, if you take this MIT open courseware courses, they will tell you that, okay, we have this, but it is within this domain. So they can't just release it publicly. So even when the data is shared, it's usually within specific communities. Everybody cannot access them. So you will find that as you go forward in your journey, and then you get an idea, you feel like, okay, I should build a model on this thing. By the time you start researching data or looking for data, you realize that you have gotten yourself in a bigger problem. Because really, data is in AI generally, data is more than half of your problem. Getting it, cleaning it, making sure it's in the format you want it to be. Data is like the most important, and it's difficult to get because of all these things that I have explained. Apart from that, if you happen to have an AI system, and if you are using an AI system, and definitely you will be feeding its data, because you build a model based on the data, and then if you want to predict or make a decision based on that data, you have to feed it more data. So that data is probably going to be stored. So there's a risk that the data will be compromised. Someone hacks into your system, and then data of people that should have been kept private is lost, or is made public where it should not be made public. So that can cause you serious problems. So we can go on and on about data, from accessing it to securing it to everything that surrounds it. So it's a problem. If we come specific to a climate like Nigeria now, Africa generally, some of our hospitals are just starting to transition to electronic health records, right? So imagine you now want to build a model, um, or you want to build an AI product and you want to get data. And then you go to a hospital and then they are using paper records. So you want to get data of, I don't know, 1 million patients for, okay, let's keep it to 1,000 patients over the past 15, 20 years. How long do you think it's going to take you to start opening the records? That's if they still have those records, in fact. So sometimes data is not even available, it has been lost. That's a unique problem. But thankfully, some of our systems are already shifting to electronic health records. So at least that should make it easier. I know in University of Abuja Teaching Hospital here, we use electronic health records. So that's one positive thing. So let me stop on the data for now, and let's go on to the next one, which is algorithmic bias. AI systems can perpetuate existing biases and inequalities in healthcare, leading to unfair outcomes. I think there has been this thing that was going around before, and what happens is that, say this image, these generative AI models now, these ones that generate images, and then you ask it, just ask a generative AI model to give you an image of a criminal, it's likely going to give you a black man, because that's the bias, that's the stigma. What do I call it? If you ask it to give you something, if you ask it to give you a drug or an image of a drug dealer or something, will likely give you an image of a black man. So that's a serious bias. That's something that is real. So the because the data that is trained on is gotten from social media, from news outlets, from sentiment analysis and all that. So it's going to just learn from that. It's going to learn from the trend of human thoughts over time. And the trend of human thoughts is that by default, the black man is the bad guy. So the AI system also assumes that the black man is a bad guy. So there is that bias. So it's not the model's fault. It's the data it was trained on. It's the data it was fed, and the data it was fed is what humans actually think. So if if we are going to have sustainable AI solutions, then we need to find a way to address this bias problem. So the next is regulatory frameworks. Regulatory frameworks. Okay. So it's surprising that if you want to build a okay, from this note we said FDA regulations for AI powered medical devices. What's FDA? Food and Drug Administration. So what concerns FDA and medical devices and gadgets that you build? So all these things are considered as electronic gadgets. So even if you build a software now and you say, okay, it's just a model now, in maybe in Africa or places around us here, there's those regulations are not too strict. You still have some free hand. You still have some liberality in how we can do things. But if you go to Europe, for instance, the regulation is so tight, so you can't just build a model and release it and say you have released something. The is considered as a digital health tool, and it has to be regulated. So you can't just do anything. I think the other time I was planning a product, and someone is unmuted. Okay, so I was planning a project, and in my head, the whole thing was looking smooth and clean, and it was looking like it made sense in my head. So I just asked someone about it, someone that has been in the space building health products. So that was in a meeting like this. So I asked, and it was like, why would you want to do this and this and this? So the idea was that the model will be collecting data post production and then using the data to train and improve the model. And it was like, why would you be doing that? Like, why do you want to collect data post production? Why should you be collecting and storing people's data? So there are regulations against that. Maybe you can get past it in Nigeria or African climate, but in places where there are these regulations are enforced, it's not going to work. You can't just start storing people's data without collecting them, without getting appropriate approval from the appropriate quarters. Another thing that might come in is this still leads back to data, because the regulation is number one, the data that you are getting. Number two, the fact that you are putting forward an health product. So it's just like you are a pharmaceutical company that's producing a drug. That drug has to be tested. It has to go through extensive clinical trials before it can be approved and adopted. It has to be checked for side effects. It has to be checked for adverse reactions. It has to be checked for drug-drug interactions. How does it affect patients' outcome in the long term? How does it interact with other disease entities? So similarly, even a digital health product is subjected to these strict and stringent regulations. So if you build a model now, how are you sure that it's doing what it's supposed to do? How are you sure that sometimes you build a model and then there's a lot of complex mathematics going on under the hood that humans do not have the processing power, so to speak, to comprehend. So how are you sure that something has not been messed up in all that math that you can't see under the hood that is bringing you biased results? So those are some of the things that you have to deal with regulations. Okay, so the next thing here, ethical considerations. AI raises ethical concerns such as ensuring patients' autonomy and transparency in decision making. For instance, ethical considerations for AI-powered end-of-life care. So we know that there are models can do triage. Okay, which patients should get priority care. There are models that can just basically follow the course of a patient's progression of a patient's illness and say, okay, probably this person is more likely to die than this one. So it now comes to the moral bias of who are you to say who should die or not? Even for human beings, doctors that are trained to understand pathologies and to understand progression of disease and disease states, even when they say, okay, this is a terminal illness, you probably have this amount of time to live, there might be some dust raising over that. So how much maybe a computer now comes and tells you that, okay, you are, you have, you likely have this amount of time to live, or this person should take more priority than this other person because I have seen this, and this in the data. What if the data is biased? What if the model is biased? What if the result is a false positive, for instance? So these are some of the ethical considerations, and we know that some persons are they have enough trouble trusting a doctor with their health. So how much more trusting a computer with their health? So if you build a model now that can say, okay, this person has diabetes, or this person has heart disease, why should why should that person that finds it difficult to trust a doctor, why should they trust a computer? So these are also some of the challenges that are faced. Okay, it's also mentioned here about patients autonomy. So do you now take away the decision about their own life and about their own care from the patient and let a computer handle it instead? So you let the computer do the triaging, you let the computer do the risk stratification, and then you just classify the patient under one risk category, and then the patient has less authority over their own care, over their own healthcare. So a lot of things ensure, even among doctors, doctors are also slow to adopt these things because they feel like, should a computer be taking my place, or should I allow a computer to do what I should be doing? Am I doing right by my patients? Should my patients not be able to trust me to make the decisions? So all these are also problems that can come in. So liability and accountability is the next point we have here. AI systems can make mistakes, leading to questions around liability and accountability. So if an AI system makes a mistake, who is responsible for that mistake? Who should be held accountable? Is it the doctor that followed what the AI said, or the technical team that built the model? Who is responsible? We can't penalize an AI model. We can't charge it to court or anything. So a human has to be held responsible. So if if an AI system makes mistakes, and some of these mistakes might be mild, not having very severe consequences, some might have a lot of direct consequences. So if there's an error, who should be held accountable? So that is another consideration, another problem, another challenge that is facing AI for healthcare. Okay, technical limitations is another challenge that faces AI, application of AI in healthcare. AI systems are not perfect, of course, and can make mistakes, requiring careful evaluation and validation. For instance, technical limitations of AI-powered medical imaging analysis. In fact, he said in AI or data science circles that you build a model and you are getting 100%, something is wrong. Something has been mixed up somewhere. You should not build a model and get 100% accuracy. You might get very close to it, but it can't always be correct. It can't always be accurate. So this alone, this alone is a serious problem because you build a model and then okay, there's an instance of medical imaging analysis here, and then the model says that this tumor that is seen here is benign, whereas it's cancerous. And then you go based on that and you say, okay, it's a benign tumor. We don't have to manage it aggressively at this stage. Or probably we can just offer some palliative care or offer some supportive care and maybe not subject these patients to surgery at this time, till a more convenient time. And then it turns out to be a metastatic tumor and then it spreads and causes further complications. This is a problem and is a technical limitation of AI for step because they can't always be accurate. You might get 90 something, you might get 97, you might get 99 point something. But what of that 0.1 that is wrong? Yeah, so and then you can also go the other way. You can also go the other way. So that's when as you go on, you begin to come across metrics for evaluating the performance of AI models from the confusion matrix. We'll learn about accuracy, precision, recall, and all that, so that you will now be able. So those metrics are just used to balance between okay, how what should be the positive predictive value, how much should we be able to trust this model when it says that this is correct and this is not correct. So and then other technical limitations in some climes. Okay, thankfully now more powerful we have more powerful systems, we have more powerful computers, we have even cloud servers now that are performing excellently well. So it's less of a concern. But in places like Africa, again, for instance, we don't have all this heavy infrastructure. So and with the trend of AI, everything now is big data. So we don't just train a model on 2,000 observations and say you have trained a robust model to deploy in practical application. That's not going to make a lot of sense, depending on the use case, anyways. Imagine you now want to check X-ray images, and then you have 1 million X-ray images, not texts. That's a lot. It requires a lot of power. So if the infrastructure is not available, it might not be very feasible. So you might just build a model, but then it's not usable because you can't deploy it to hospitals, for instance, or you deploy it and then the technical personnel to run it are not present. Okay, the next thing is clinical validation. AI systems require rigorous clinical validation to ensure safety and efficacy. So I think I've mentioned this before when we are talking about, I think the algorithmic bias or one of those other points. I think I mentioned about clinical validation. So you have to just ensure that this thing works well, even though you don't get 100%. The performance of that model should be able to at least equate the currently preferred method of measuring that particular parameter you're measuring. Excuse me. So for instance, you want to predict you want to build a model that deals with say chest x-rays, and we are now comparing the performance of the x-ray with that of say a consultant radiologist, someone that is or a professor in radiology, someone that is respected in the field. So you want to ensure that at least this model performs as well as this human, if not better. If the model performs better, that's good. But if the human performs at say 85%, say 85% of the time, the human is correct, then you now have the model performing correctly at 60 something percent of the time, then just throw the model away and let the human continue his job. But if you can now make the human, if the human can, rather, if the model can also perform at say 80 something percent, or better still, their combined performance can now shoot up to say 90 something, then okay, yes, you have a tool indeed that you can use. Okay, so this is just in addition to what I've said before on clinical validation. Healthcare workforce displacement. This is not just in healthcare, this is everywhere. Since this AI thing have been coming up, there has been the uproar that AI is going to take over jobs, it's going to displace people from their jobs, it's going to cause a lot of unemployment. And then some people will come and say, no, it's only those that don't know how to use it is going to displace. So it's a real concern everywhere, including healthcare. So for instance, now we have systems that can dispense drugs effectively. So you just go to the system with your prescription, and it's just going to, or maybe the doctor even just sends the prescription to the system from his own computer, and you just go there, put in your hospital number, and then it dispense the exact dosage, the exact count of pills that you need for you. So the guy that was selling the drugs before, the guy that was working at that dispensing points before, what is he going to do? So that is a concern. We talked about X-ray imaging now, for instance. So if we have more reliable radio radio models that can analyze maybe X-ray, CT scans, and all that, that means, and hospitals are adopting this, that means we are going to need fewer radiologists. So just maybe need a one or two that will be maybe validating or confirming or just monitoring what the models are doing. So that is a problem. If we have a model that can effectively triage, maybe in an accident and emergency unit, for instance, the nurse that was in charge of that or the doctor that was in charge of that, that is a reduced work for them. So it reduces the workload, but it can also reduce the workforce. So maybe in healthcare, maybe it might not get so bad so soon, but you know that progression of things, it's likely going to happen. If we can have remote surgeries, that means we can just have one consultant working in, say, consultant neonatologist that will be performing operations right from say United States, and the operation is happening in Nigeria. So that means the Nigerian hospitals will feel like, "Okay, since we have someone good that is doing it from over there, we don't need to employ people around here." So that is also a real concern. It's a real concern. The next point here is patient trust and acceptance. I think I've made a mention of this also before. In Africa, particularly, people, okay, the trend is getting better now, at least. But we still know that if you go to the more rural areas and maybe even in the urban areas, people don't really put their confidence in the healthcare system, probably for personal reasons or for political reasons or for, okay, it's Nigeria, it's Africa. So people don't trust, people don't accept enough. And so how much more a computer? If you can't trust a human to take care of you, how will you trust a computer that can't even feel what you are feeling or can't understand what you're passing through? So I've dwelt on this earlier. I don't need to dwell on so much again. Cybersecurity risks is another concern. So this still comes back to the data, because data is a lot. So AI systems can introduce new cybersecurity risks requiring robust security measures. So number one, the data can get attacked and stolen. Data can be stolen. That is even better than if data is corrupted. So someone hacks into the system and does messes with the data or messes with the model itself. So you have trained the model and you feel like, okay, this model is performing excellently well. Your system gets hacked and then someone messes with the model, replaces the model, and then you feel like you still have the same model, but they are changing the model. So a model that was performing at 97, 98 before, unknown to you, the model is now performing at 40 something because someone has messed with it. So you are going to have a lot of misdiagnosis. You are going to have a lot of things that will go wrong. If it's a triaging system, you are going to have a lot of wrong things. Someone that should get immediate attention is going to be ignored by someone that is relatively healthy and fine to get attention. The other one is left to maybe die or deteriorate. A system that I mentioned dispense drugs, for instance. can dispense the wrong medications, and that can have great consequences. Uh, if you are having remote surgeries, for instance, someone can hack into the connection, surgeon loses control. These things can get really, really dangerous. So it opens a lot of other threats. And because it's healthcare, because it's dealing with human life, because it's dealing with everyone holds human life dearly, everyone holds it with sanctity. So if there's any risk at all, it's, it's particularly of greater concern than if it was in other field. So finally, navigating the integration of AI in healthcare requires a comprehensive approach that addresses various challenges, and by proactively addressing these issues, can foster trust, ensure patient safety, maximize potential of AI to improve healthcare delivery and outcomes. So we have talked about data privacy and security, and what we can do in that regard is just we can't pretend we know everything. We can't pretend we are experts everywhere. So we can bring in cybersecurity experts on this. We can we can invest in highly secure infrastructures so that we can really avoid data breach. And with the idea of with the area of privacy, what's the one feasible solution is that whatever you are with data, whenever data is being shared, the data should be anonymized. So any personal identify what's the name now? I think personally identifiable data should be stripped off. If you have done a survey and gotten some data, if you likely won't need the name. Some data are not necessary to train a model. You don't need the name. Exclude the name. Don't store the name. You you don't need the hospital number. Remove that. You can replace it with other form of ID. You don't need you don't need, you probably depending on the model you are training, but for if you don't need a lot of demographic data, you don't need state of origin, remove it. And other data that address, yes, the person's address, depending on the model again. If you don't need the address, remove it. So all those personally identifiable data, something that can be traced back to the person. If it's not needed for your model, remove it. Algorithmic bias, just ensure that you select the right algorithm, select the right methods for transforming your data, do proper validation of your the regulatory frameworks, ensure that you are within regulations as much as possible. And admittedly, there are regulations that are actually limiting, and they are pulling back on the extent of work that can be done for you in health. So we can have collaborations to reach more comprehensive agreements that work well for everybody. Ethical considerations, yeah. So we just need to they are fundamental principles already. So we just need to build on those to apply also into AI for health. Liability and accountability. This is something, because who I'm still asking myself, who is going to be held responsible. So I think that just goes back to ensuring that we have a robust model. We have a robust model so that we can avoid litigation altogether, because litigation is becoming a bigger issue by the day. Okay. Technical limitations. Again, this still talks about the model. So ensure you have a well-performing model, well validated, invest in the infrastructure necessary. Validation, we've talked about this already. Healthcare workforce displacement. And I think what we can do here is just, instead of allowing the AI to phase out healthcare workers, we can retrain them to take advantage of these tools. So these tools are not here to maybe displace, they are here to aid. So another thing is, why the AI tools are taking over the more routine jobs, they are taking over some, then this should free us up. We should not take it as a threat. We should not take it as something that is stressing us and striving to push us out of our jobs. Rather, we should take it as something that is freeing us up from the mundane things and allowing us to go further to explore the frontiers of healthcare, to explore other problems that we need to do. So imagine if you don't have to cook anymore, you don't have to wash plates or wash clothes anymore. If you have your time free, you can explore other things that you can do. So you can apply the same principle in healthcare. Patience, trust, and acceptance. So we just need to maybe sensitization symposiums, and to ensure that patients trust these things. We should have demo right in front of the patient and say, okay, this is what this thing is doing. We trained it, or we made it so that it will do this and this and this. So we can trust it. We know that it's giving us the correct results. We can give them instances where it has given the results, where it has really been of use so that patients can come to trust and accept this. We should consult patients before building models. What do they need? What are they comfortable with? The same goes for healthcare professionals that are reluctant to adopt these digital health tools. They should be consulted before these tools are built. The tools should be built with the doctors involved. Let them know what's going on. If you are making a decision to use feature A, B, C, and not feature D, E, F, let them understand why you are choosing to use those features, or else they are going to just block you out that you are trying to override the authority. Cybersecurity risks, we have talked about this earlier. So thank you for listening, and I believe that these are the challenges we have said, but we also know that as much as there are challenges, opportunities abound much more, and there's a lot for us to explore. That despite the challenges, we can still get things done. So thank you very much for listening. And if there are questions, I will be happy to, or additions, I'll be happy to listen to them. So I'm taking that there's no question, no confusion, no addition, clarifications. Feel free
All
to
right.
unmute.
Yeah, thank you, Maradesa. It has been an insightful presentation. So, dear scholars, so if anybody has any question or anything that requires clarification, please put it on the chat in the chat, or just unmute yourself and ask so that Maradesa can actually trash it out. I can see one of the questions here already. It says, as the AI replaces some healthcare jobs, so smarter individuals train themselves to use AI, creating jobs opportunities for the smart ones. Wow. That's a statement from Rita Dan. Yeah. So as AI is replacing some aspects of our work, we are becoming smarter. We are actually becoming smarter. And that's one of the reasons why we actually here. Yeah. So thank you, sir, for a wonderful presentation. That's from Chipike Wafu. Yeah. But if anybody has a question, let the person ask. You can ask
So just
the question, you can unmute so that our mentor can actually address them. But if there are no questions, I think I have my own question.
so you just wanting just to respond to what Rita said. So yeah, that's exactly the point we're making. So
Okay.
if a doctor doesn't have to worry about taking clinical notes, I mean writing and typing and documenting, you the doctor has more time to attend to more patients. If he doesn't have to worry about pursuing lab results around, and we have the systems in place that you actually get the lab results done, or have to sit down and interpret lab results, and there's actually a model that can do that. The doctor can focus more on other aspects of the patient's well-being. And like I said, overall, as we have these tools taking over the mundane routine things that we do, we can open our minds to the problems, the bigger problems, and the bigger questions that are yet unanswered. So yeah, thank you very much for the contribution, Rita.
All right. So that has been an amazing section. And we've actually spent, say, 40 minutes. So this is just one, or the first mentorship section for artificial intelligence for this week. There are still two more remaining. So on Thursday by 2 p.m. to 3 p.m., Maruf is going to come on board and take us on another MIT AI mentorship section. And come Saturday, that should be 3 to 4 p.m. Another person in the person of Ajibade is also going to take us on a third MIT mentorship section for the week. So these sections are rich, they are engaging, and they throw a lot of light to gray areas we might have issues. So whether you are in the MIT AI class, as a foundational AI class for healthcare, or you are not, avail yourself of the opportunity and be in these mentorship sections. For those who are not in the foundational AI class, you still have a window of opportunity to get in. But at the close of this week, that window of opportunity will be closed so that you can't get in until the next cohort. So if you are still willing to join the class, because the class not only joins the mentorship section, they have reading materials, they have videos to watch, they have assignments to submit, and they are graded. And at the end of the 6 weeks of their training, they are going to be given a certificate to certify that they are actually ready with the skills and knowledge to implement, basic AI literacy in their healthcare practice. So if this is what resonates with you, then you have to get into the MIT Artificial Intelligence class. Currently, we are offering Foundational Artificial Intelligence, a course in healthcare, and this is the second week. But after this week, then that window will close. So if you are still here, send a DM in the chat, WhatsApp group, so that you will be included. So if you are hearing me later on, probably it will be late by then. But however, if you are here and listening and you want to join the full class to access the learning materials, the videos, and every other thing, and also the assignments and the grading, then you need to join the MIT Foundational Artificial Intelligence class, which started last week. So admission is closing this week. And next cohort will be like after 6 weeks. So thank you all for coming. We appreciate everyone, LPTCPC, Neji, Onoha, Luella, Rita, Dandi, Uchechi, Irebuzena, Omaru Farouk. So it was an amazing section. And the recording will be provided for those in the MIT AI class, for review, especially for those who couldn't make it. Yeah, thank you so much. Yeah, it's been and we thank you, our mentor, and we hope to see you again this same time next week. Yeah, Maradesa, Ebenezer is going to be, on set again Tuesday next week, same time. So ensure you come to listen again when he comes up with another amazing section. Yeah. So with that said, I think that should be the end. Everyone should be retiring now. Bye-bye, everyone.